All right, everyone, we have made it to week 3, where we are talking about pharmacology and comparative efficacy. So, I'm going to get into some of the neurophysiology, some of the receptors that we're playing with, some of the terminology for what we're learning about this semester. All right, so the first chapter that we're talking about is the pharmacology of psychedelics. And ultimately, this is a serotonin receptor. Here's the synaptic gap, the neurons. So just giving you like a little bit of a visual of um, some of the neurotransmitters and some of the connections that I'll be talking about in this lecture. Okay, so again, heavy on pharmacology in this week. But I want to be very clear about why the pharmacology matters to therapists. This is not about turning you into prescribers or neuroscientists or anything like that. So psychedelics, classic psychedelics, or serotonergic. Psychedelics are serotonergic agents. So serotonergic means that it works on serotonin receptors, meaning that their primary effects occur through the serotonin system, which is deeply involved in mood regulation, perception, emotional processing, and sense of self. These are the exact domains that we work with clinically. So the relevance here isn't theoretical. Clients come into therapy already shaped by medications, curious about psychedelics, or sometimes actively using them, whether it's legally, illegally. When therapists don't understand pharmacology, we either avoid the conversation or inadvertently give misinformation. So, this chapter is to move us beyond drug facts and toward understanding how neurobiology intersects with meaning, insight, identity, and relational change. Okay, so the authors are very intentional about definitions. So psychedelics are not just any hallucinogen. And quite frankly, I actually just read an article. I think I'll post it in Canvas, or maybe I'll post it in the Google Doc about the lexicon of psychedelics. So hallucinogens are sometimes used sometimes interchangeably with psychedelics, but I think the field is getting away from the use of the term hallucinogens because of its like kind of pejorative or stereotyped or just like uh, tough background or tough association with things like mental health diagnoses. But anyway, so psychedelics are not just any hallucinogen, they are specifically serotonergic hallucinogens. So classic psychedelics include LSD, psilocybin, mescaline, and DMT. What unites them is not their cultural reputation, but their shared mechanism of action through serotonin receptors. So this distinction matters because other substances like ketamine or cannabis or MDMA may also alter perception, but they do so through entirely different neurochemical pathways. So clinically, this matters because mechanism shapes experience. The emotional tone, risks, therapeutic potential, and integration needs differ dramatically depending on how substances work in the brain. Okay, so this chapter gives us a brief historical grounding, not just for nostalgia, but to contextualize how these substances entered Western science. So mescaline was isolated from peyote in the late 1800s, and LSD was discovered accidentally in 1943. Psilocybin was identified through the study of indigenous mushroom use. What's important here is that these substances were not originally framed as recreational drugs. They were studied as tools to explore consciousness, perception, and psychopathology. It's also important to name that indigenous knowledge systems were foundational, even though Western science often extracted from them without appropriate acknowledgement or reciprocity. Okay, so early psychiatrists noticed similarities between psychedelic experiences and psychosis, leading to the idea that psychedelics could model schizophrenia. LSD was even distributed to clinicians so they could take it themselves with the belief that this would foster empathy and insight into their patients' internal worlds. This period coincided with the discovery of serotonin in the brain. Because LSD and serotonin share a molecular scaffold, researchers hypothesized that mental illness might be rooted in serotonin dysfunction. While these theories were incomplete, they correctly identified serotonin as central to perception, cognition, and emotional regulation. One of the earliest pharmacological clues was that psychedelics produced rapid tolerance, often after just one or two uses. Even more importantly, tolerance to one psychedelic often generalizes to others, which strongly suggests a shared biological mechanism. Clinically, this is significant because it differentiates psychedelics from addictive substances. There is no pattern of escalating daily use driven by tolerance in the same way we see with substances like opioids or alcohol. So early models proposed that psychedelics worked by suppressing serotonin release from the dorsal raphe nucleus, which would then disinhibit other brain regions. This theory eventually failed because not all psychedelics affected the raphe nucleus in the same way, and because non-psychedelic drugs could produce similar suppression without psychedelic effects. This is an important scientific lesson. Just because a drug affects a system does not mean that effect explains the experience. Okay, so decades of research converge on one central finding. Activation of the 5-HT2A receptor is required for psychedelic effects. Psychedelics act as agonists or partial agonists at this receptor, meaning they activate it directly. So an agonist activates, an antagonist deactivates. When this receptor is blocked, most famously with ketanserin, the psychedelic experience is largely eliminated, even though the drug remains in the body. This anchors subjective, often mystical experiences in a very specific neurobiological process. All right. So 5-HT2A receptors are concentrated in brain regions involved in self-reflection, emotional meaning, and sensory integration. The colostrum, which has the highest density of these receptors, is especially intriguing because it appears to coordinate communication across large-scale brain networks. This helps explain why psychedelic experiences feel global rather than localized. So these other, the prefrontal cortex, the anterior cingulate, the thalamus, and the amygdala are also all regions that are affected that have 5-HT2A receptors. All right. So psychedelics directly activate only a very small subset of neurons, sometimes fewer than 5% in key regions. These neurons act as a trigger population, initiating widespread changes across the brain. Clinically, this supports the idea that small interventions, when targeted correctly, can create disproportionate psychological change. Okay, the default mode network, or the DMN, is associated with self-referential thinking and narrative identity. Psychedelics reduce the dominance of this network, allowing other brain regions to communicate more freely. Subjectively, this often feels like ego dissolution, loss of rigid self-concepts, and expanded perspective, which allows for some identity transformation. So, despite intense psychological effects, classic psychedelics are physiologically very safe in controlled settings. They do not produce organ damage or physical dependence. Most adverse outcomes are related to context, psychological vulnerability, or unsafe environments, not toxicity. Okay, so this slide is here intentionally to interrupt a common narrative that students will encounter both in popular media and even in some clinical conversations, that psychedelics are safe. The authors here are very clear. This is called the N-bomb. The N-bomb compounds are not classic psychedelics, even though they act strongly at the 5-HT2A receptor. They are synthetic N-benzophenethylamines that are often misrepresented as LSD because they can be laid on blotter paper. Their extreme potency is a major problem. Very small dosing errors can lead to severe physiological consequences, including seizures, cardiovascular instability, hyperthermia, kidney injury, and death. Clinically, this matters because clients may not know what substances they actually took. From a therapist standpoint, safety conversations must include drug identification, testing, and harm reduction framing, even if you are not endorsing use. So this slide's also a reminder that mechanism alone does not guarantee safety. Potent 5-HT2A activation without regulatory balance can be dangerous. All right, so much of what we know mechanistically about psychedelics comes from animal research, particularly rodent models. So, drug discrimination is especially important because it measures the internal interoceptive effects of a drug. Animals are trained to recognize the subjective feel of a substance, which maps surprisingly well onto human subjective experience. The head twitch response is a visible motor behavior that reliably indicates 5-HT2A receptor activation. However, it does not mean the animal is having a psychedelic experience as humans would describe it. Behavioral pattern monitoring looks at exploratory behavior, avoidance, and locomotion, helping researchers understand how psychedelics alter environmental engagement. For therapists, the key takeaway is not the specifics of the models, but the idea that subjective experience can be operationalized scientifically, even if meaning itself cannot be reduced to behavior. So, this slide is about epistemological humility. Animal models are proxies, not direct representations of human experience. They tell us about receptor activity and neural signaling, not insight, trauma resolution, or meaning making. The authors explicitly note that false positives can occur. Drugs that activate the same receptors but do not produce psychedelic experiences in humans. For therapists, this is an important caution when reading headlines that claim X compound works like psychedelics. Translational work requires human studies, therapeutic context, and psychological assessment, not just receptor binding data. Okay. So psychedelics do bind to the 5-HT2C receptor, which initially confused researchers. However, extensive evidence shows that blocking 5-HT2C receptors does not eliminate psychedelic effects, while blocking 5-HT2A receptors does. This distinction is crucial. Binding affinity is not the same as functional relevance. Clinically, this teaches you to be cautious when reading simplified explanations of how drugs work. Multiple receptors may be involved, but not all are equally responsible for the lived experience. The 5-HT1A receptor plays a modulatory role, particularly in shaping emotional tone and intensity. Activation of the 5-HT1A receptor can dampen visual intensity, anxiety, or overstimulation, which helps explain why different psychedelics feel subjectively different, even though they share 5-HT2A activation. Importantly, this receptor is only heavily implicated in anxiety and mood regulation, which is highly relevant for therapists. Clinically, this helps us understand why some experiences feel calming and relationally open, while others feel organizing or overwhelming or disorganizing. All right, so MDMA is often lumped in with psychedelics, but pharmacologically it is distinct. Rather than directly activating serotonin receptors, MDMA induces the release of serotonin along with dopamine and norepinephrine. Subjectively, this produces empathy, emotional openness, and reduced fear without strong perceptual disorientation or distortion. This pharmacology aligns closely with its use in PTSD treatment, where emotional engagement and relational safety are central. For therapists, this underscores how mechanism shapes therapeutic processes. So MDMA is considered an entactogen or an empathogen, so different from classic psychedelics like psilocybin. Okay, so psychedelic experiences are not treated as ineffable or purely anecdotal in research. The APZ, or the abnormal mental states, and its updated version, the 5DASC, or the five-dimensional altered states of consciousness, measure three core dimensions: oceanic boundlessness, which is OB, which measures feelings of unity, transcendence, and positive depersonalization. Anxious ego dissolution, which is the AED. This measures fear, disorganization, and loss of control. And the visual restructuralization, or VR, which measures perceptual changes and imagery. So these distinctions are clinically important because not all intense experiences are therapeutic. Anxiety-dominated experiences require different integration work than mystical ones. Okay, the HRS, or the hallucinogen rating scale, expands assessment into bodily sensations, affect, cognition, perception, volition, and intensity. This allows researchers and clinicians to understand how different substances emphasize different domains. From a therapy standpoint, this helps normalize the wide variability clients report and supports non-pathologizing curiosity. Early clinical studies were small but foundational. In OCD, symptom reduction often extended beyond the pharmacological presence of the drug, suggesting something more than symptom suppression. In healthy volunteers, psilocybin frequently produced experiences rated as among the most meaningful of participants' lives. Importantly, outcomes correlated more strongly with subjective experience than with dose, reinforcing the importance of psychological context. So, psychedelics do not broadly destabilize personality. Instead, research consistently shows increases in openness, particularly when mystical experiences occur. Openness is associated with emotional awareness, creativity, and psychological flexibility, traits highly relevant to therapy. Clinically, this suggests psychedelics may create windows of growth rather than wholesome personality change. Psychedelic assisted therapy has shown promise across multiple domains, including depression, anxiety related to terminal illness, and addiction. Across studies, therapeutic benefit is strongly linked to meaning making and integration, not simply neurochemical action. This reinforces the therapist's central role, or the role as central, not ancillary to outcomes. All right, so human studies using receptor antagonists confirm that 5-HT2A activation is necessary for psychedelic effects. Imaging studies show that blocking this receptor prevents both subjective experiences and corresponding changes in brain activity. So, this convergence of subjective report, pharmacology, and imaging strengthens confidence in the model. Ayahuasca introduces complexity because it combines DMT and MAO inhibitors, or monoamine oxidase enzyme. So MAOI is monoamine oxidase enzyme, and other bioactive compounds. While 5-HT2A activation is still central, it does not fully explain ayahuasca's effects. This complexity reminds us that plant medicines are not single mechanism interventions, which has implications for both research and clinical framing. One of the most surprising findings in recent research is the potent anti-inflammatory effects of psychedelics at sub-perceptual doses. This opens the door to potential medical applications that are separate from the psychedelic experience itself. Clinically, it also complicates simplistic narratives that equate therapeutic benefits solely with subjective intensity. Psychedelics induce changes in gene expression related to plasticity and learning. These changes may help explain why psychological shifts can persist long after the drug has left the body. For therapists, this provides a biological rationale for why timing, integration, and follow-up therapy matter so much. Pharmacology sets the stage, but therapy directs the play. Understanding mechanism helps therapists collaborate, set expectations, and respond ethically to client curiosity. Without integration, neuroplasticity can reinforce maladaptive patterns just as easily as healing ones. So, this chapter gives us the pharmacological foundation needed to ask comparative questions. When do medications help? When does therapy help? And when does integration produce the best outcomes? These questions are what we will continue to explore as we move into our next article and deeper into this week's material. All right. So this has essentially looking at various like psilocybin and comparing that to um, escitalopram. Sorry, I always mess this one up. And escitalopram for depressive symptoms. So looking at psychedelics versus escitalopram. Okay. This article is one of the most important readings in this course because it does something rare. It directly compares psychedelics to a standard antidepressant, escitalopram, using a rigorous analytic approach. Many of you will encounter psychedelic research through headlines claiming psychedelics outperform antidepressant, and this paper complicates that narrative. What makes this study especially relevant for therapists is that it examines not just whether something works, but how study design, placebo effects, and expectancy shape perceived effectiveness. This article is less about promoting psychedelics and more about teaching us how to critically read efficacy claims. All right, so the authors set out with a very specific goal to evaluate the comparative effectiveness and acceptability of psychedelics versus escitalopram for depressive symptoms. Importantly, they focus on oral monotherapy, meaning no concurrent antidepressants and no injectable agents like ketamine. A central concern driving this study is unsuccessful blinding. Because psychedelics have obvious subjective effects, participants often know whether they received the active drug, which can inflate treatment effects. This study explicitly attempts to correct for that bias. In traditional antidepressant trials, participants often cannot tell whether they are on medication or placebo. In psychedelic trials, this is rarely true. Participants almost always know whether they received the psychedelic. This creates a major problem called expectancy effects. If someone knows they received the quote, real drug, hope, meaning, and motivation can increase independently of pharmacology. The authors argue that many previous meta-analyses failed to adequately account for this, leading to overestimated effect sizes. Okay, so this was a systematic review and Bayesian network meta-analysis, meaning the authors synthesized data across multiple randomized controlled trials. A network meta-analysis allows for indirect comparison between treatments that have not always been directly compared head to head. Importantly, only randomized controlled trials were included, which strengthens internal validity. The psychedelics included spanned both classic psychedelics and entactogens. Psilocybin, LSD, and ayahuasca act primarily through serotonergic psychedelic mechanism, while MDMA functions differently by releasing serotonin. Escitalopram was included as the antidepressant comparator, specifically at 10 milligrams to 20 milligram doses, which are standard clinical doses. This inclusion allows us to anchor psychedelic outcomes against a familiar pharmacological baseline. Participants were adults with clinically significant depressive symptoms, including major depressive disorder and depression associated with serious mental illness. Healthy volunteer studies were excluded to keep the focus on clinical relevance. This matters because treatment effects often differ substantially between healthy volunteers and clinical populations. The primary outcome was change in depressive symptoms measured using the Hamilton Depression Rating Scale, or the HAMD 17. The authors used a minimal important difference of 3 points, meaning changes smaller than that may be statistically significant but not clinically meaningful. This distinction is crucial for therapists because clients care about felt improvement, not just p-values. Secondary outcomes included dropout rates and severe adverse events such as hospitalization or suicide attempts. These outcomes help assess not just effectiveness, but tolerability and safety, which are essential for clinical decision making. So this is the methodological heart of the paper. Rather than treating all placebo responses as equivalent, the authors separated placebo responses from psychedelic trials and antidepressant trials. Why? Because placebo responses tend to be lower in psychedelic trials, likely due to unblinding. Without separating these, psychedelic effects appear artificially large. Psychedelic trials often use extremely low doses as active controls, assuming they are inert. This paper challenges that assumption, showing that even very low doses may produce effects. Dosing distinctions are therefore essential when interpreting efficacy claims. The authors found that placebo response was significantly higher in antidepressant trials than in psychedelic trials. This supports the concern that psychedelic trials may underestimate placebo effects, thereby overestimating drug effects. This finding alone reshapes how we interpret the psychedelic literature. When psychedelics were compared to placebo within psychedelic trials, many appeared effective. But when compared to placebo responses from antidepressant trials, where blinding was stronger, only high-dose psilocybin remained superior. This dramatically narrows the field of robust findings. One of the most striking findings is that effect size for high-dose psilocybin dropped from large of a 0.88 to small 0.31. So remember that large to small effect goes from 1 essentially to -1, or 1 to 0. 1 is large, 0 is none. Um, once corrected for placebo bias. This places psilocybin squarely in the same range as standard antidepressants. This does not mean psilocybin is ineffective. It means its effects have likely been overstated. So when directly compared, only high-dose psilocybin outperformed escitalopram at both 10 milligrams and 20 milligrams. No other psychedelic showed consistent superiority. This suggests that claims about psychedelics broadly outperforming antidepressants are not supported by careful analysis. Importantly, none of the interventions, including psychedelics, were associated with higher rates of discontinuation or severe adverse events. This supports the idea that in controlled settings, psychedelics can be as safe as conventional antidepressants. The greatest strength of this study is its methodological restraint. By correcting for placebo response differences, the authors provide a more realistic estimate of treatment effects. This paper models how to resist hype while remaining open to innovation. The authors are clear about limitation. Psychedelic trials are small, often short-term, and typically include psychotherapy, making it difficult to isolate pharmacological effects. Long-term comparative outcomes remain unknown. For therapists, the takeaway is not that psychedelics don't work, but that they work about as well as existing antidepressants, at least pharmacologically. Their unique value may lay in how they facilitate meaning making, openness, and engagement in therapy, not in superior symptom reduction alone. Clients may come in believing psychedelics are dramatically more effective than antidepressants. This paper equips you to respond with balance, evidence-based information. As therapists, your role is to contextualize medication effects within broader psychological and relational processes. So, when we zoom out, this article reinforces a central theme of this course. Pharmacological tools are helpful, but limited. Whether we are talking about SSRIs or psychedelics, effect sizes are modest. Therapy, especially relational, meaning focused work, remains essential for sustained change. And that's all I have for you this week, y'all.